My name is Heidi Hegsted, and this is a review of femoral block placement. Surgical indications for use: femur, patella, quadriceps tendon, knee surgery, hip fracture. Femoral nerve block results in anesthesia of the anterior and medial thigh down to and including the knee, as well as a variable strip of skin on the medial leg and foot. It also innervates the hip, knee, and ankle joints. It is important to look at the diagram to the right, noticing that the femoral block covers all areas in blue. If the surgery requires coverage in the red areas, an additional block will be required. Pre-procedure preparation. Ensure the patient understands the procedure, the risks, and benefits. Obtain informed consent from the patient. Before you begin, ensure you have the necessary equipment: sterile gloves, a sterile drape, antiseptic solution, a 20 and a 3 cc syringe, a B-beveled insulated needle, local anesthetic, and a nerve stimulator. For ultrasound guidance, ensure the machine has a linear transducer, sterile sleeve, and gel are available. Position the patient supine on the operating table or examination bed. Keep the patient lying as flat as possible to maximize operator access to the inguinal area. If the patient is obese, use wide silk tape to retract the pannus out of your field. Review of anatomy. Visualize the femoral triangle. The top of the triangle is the inguinal ligament, the sartorius muscle, and the gracilis muscle. Within the triangle, you will find the vein, artery, and nerve. The femoral nerve is enveloped inside of the fascia iliaca, and the fascia iliaca is where you will want to instill the local anesthetic. Cleanse the area with betadine, starting from the center and working your way away from the site in a circular motion. Once the betadine has completely dried, you will want to place a sterile drape. There are two techniques you can use to place a femoral block. Use a nerve stimulator, use an ultrasound machine. With your non-dominant hand, palpate the femoral artery by feeling the pulse. Continue to palpate the femoral pulse as you move distal to the femoral crease. With the pulse isolated, you will come distal 1 centimeter and lateral 2.5 centimeters. This will be the injection site for your block. Turn the nerve stimulator on. Program the stimulator to start at 1 MA. Place your needle at a 45-degree angle and aim the needle cephalad and away from the artery. Start more lateral and gradually work more medial until the nerve stimulator indicates you are close to the nerve. You should feel the needle pop through the fascial plane. The pop, as well as the feedback from the nerve stimulator, is how placement is verified. Once you get to the area and you see twitches, you will come down on your nerve stimulator, and the twitches should slowly diminish until you hit 0.3 MA, and twitches should stop. At this time, aspirate to ensure you are not in the vasculature. If no heme is aspirated, instill 5 mL of local anesthetic. Again, aspirate and instill 5 mL of local anesthetic, and continue this process until 20 mL of local anesthetic has been injected. With the assistance of ultrasonography, identify the femoral artery at the level of the femoral crease. Commonly, the femoral artery and the deep artery of the thigh are both seen. The femoral nerve is lateral to the vessel and covered by the fascia iliaca. It is usually triangular or oval in shape. The nerve is enveloped within 2 layers of the fascia iliaca and can be visualized at a depth of 2 to 4 centimeters. In order to identify the femoral nerve, it is best to tilt the transducer cephalad or caudal. This helps contrast the nerve from the background. Applying pressure to the transducer also optimizes the image. Caution should be used as to not compress the surrounding veins. It is best to visualize the nerve, then release pressure prior to injection of local anesthetic. Identify anatomical landmarks. Place the transducer transversely on the femoral crease, over the pulse of the femoral artery. Move the transducer slowly in a lateral to medial direction in order to identify the artery. Identify key landmarks such as the inguinal ligament, the femoral artery pulse, and the femoral nerve's expected location, just lateral and deep to the artery. It is important to note that there is not a guarantee that the anatomy will be replicated as in textbooks. In some cases, the vein may lie on top of the artery instead of next to it, or the artery may lay on top of the vein. It is imperative that extreme caution is used when identifying landmarks prior to injection. The femoral nerve should lie lateral to both the artery and the vein. Here are some ultrasound examples of how the vasculature can be different than what is seen in a textbook. In number 1, you can see that there is extra vasculature there. It may not always lie perfectly vein, artery, then nerve. In the second picture, you'll see that the artery is lying on top of the vein. And in pictures 3 and 4, you can see the artery and the vein, and sometimes it's hard to differentiate between the two. So with your transducer, if you apply pressure, the vein is much easier to collapse than the artery. Place the transducer transversely on the femoral crease over the pulse of the femoral artery. Move the transducer slowly in the lateral to medial direction in order to identify the artery. Insert the needle at a 45-degree angle from the skin, just below the inguinal ligament and lateral to the femoral artery pulse. Advance the needle slowly and gently to avoid accidental vascular puncture. If you have a nerve stimulator, use it to confirm proximity to the femoral nerve by observing muscle contractions and paresthesia. The goal is to place the needle tip immediately adjacent to the lateral aspect of the femoral nerve below the fascia iliaca or between the two layers of the fascia iliaca that surround the femoral nerve. Aspirate for blood to ensure there is no intravascular injection. If no blood is aspirated, inject the local anesthetic slowly to create a spread of anesthetic around the femoral nerve. Never inject against high resistance. Proper deposition of local anesthetic is confirmed either by observation of the femoral nerve being displaced by the injectate or by the spread of the local anesthetic above or below the nerve, surround and separating it from the fascia iliaca layers. The appropriate volume and concentration of the local anesthetic will depend on the specific clinical situation, but it is common to inject 20 mL. Proper injection will push the femoral nerve away from the injection. It is not necessary to obtain circumferential spread around the nerve. A pool of local anesthetic immediately adjacent to either the posterolateral or the anterior aspects is sufficient. Once you've instilled 20 mL, remembering to aspirate at least every 5 mL, you will go ahead and retract your needle. Wait a few minutes to assess the onset of anesthesia or analgesia in the femoral nerve distribution area, which includes the anterior and the medial thigh. Document the procedure by recording the details of the procedure, including the volume and type of local anesthetic used, the patient's response, and any complication. Monitor the patient after the procedure for any adverse effects or complication, such as local anesthetic toxicity, bleeding, or injury to nearby structures, and provide the patient with post-procedure care. Remember, the patient will have a loss of sensory and motor function, and the patient should not ambulate until both sensory and motor function return. Safety first. Using the ultrasound is the gold standard for placing a femoral block, and the needle placement and orientation is very important. It's really important that when you're using the ultrasound, you take your transducer and you're able to see the needle coming in from the lateral side, working your way towards the nerve. This way you can ensure that as your needle is passing through, you are not near the artery. When you're doing the nerve stimulator, you obviously do not have the same visualization as you would with the ultrasound. So you need to take your needle and insert it, working cephalad. You're going to start more lateral and then work your way more medial until you get the feedback from your nerve stimulator that you're close to the nerve. We want to be extremely cautious with this approach because getting the artery is a big risk. Thank you so much for watching.